Thank you for this opportunity to present our work evaluating a ScarWork service for cancer survivors experiencing adverse effects of surgery and/or radiotherapy. My name is Beverly de Valois, and I have no conflicts of interest to declare. I'd like to set the context for this presentation. In the Supportive Oncology Research Team, we have a three-step ScarWork program, and today I'm presenting on step 2, our one-year clinical outcomes. I'd like to acknowledge our funders, the Millie Apthorpe Charitable Trust and the East and North Hertfordshire Hospitals Charity, as well as the Linda Jackson Macmillan Centre, where we had clinical space, and also my co-researchers and co-ScarWork colleagues. In the UK, 68% of early cancer patients undergo tumour resection, and the resultant scars may have wide-ranging consequences that can affect them on a psychosocial and physical level, and they may have to live with troublesome sensations. And in spite of the potential impact on quality of life, there is little clinical or research attention given to scar work in cancer survivorship. So, in the Supportive Oncology Research Team, we're very interested in exploring scar work. This is a light touch manual therapy that is hands on, using no lubricants or medical devices, and it specifically addresses the changed elastin and collagen associated with pathological scarring, as well as scar related tissue damage, including fibrosis, adhesions, and contracture. ScarWork was developed by Sharon Wheeler in the USA, and this novel therapy was introduced to the UK in 2014. To date, there is scant evidence in the medical literature. Wheeler et al. Have published one abstract. So the aims of our service evaluation were to build on previous work that we'd done with head and neck cancer patients, which I presented yesterday, and we wanted to assess scar work on a range of tumor sites. So in addition to head and neck cancer, we were looking at breast, colorectal, and melanoma patients. And we wanted to explore the symptoms that patients find troublesome, the effect of scar work on these symptoms, and the usefulness of the outcome measures that we were using. And this was to start to build an evidence base for clinical outcomes for scar work, and also to collect data to justify funding for service and research development. So we had funding to set up a clinic 1 day a week for a year. That ran from April 2019 to mid-March last year. And we offered 8 one-hour treatments to each patient, and they would come once every 2 weeks for treatment. They could be referred by themselves or by their healthcare professionals, and patients gave written consent for us to use their de-identified data and photographs. We used validated patient-reported outcome measures at baseline and end of treatment, and the two we chose were the Patient Scar Assessment Questionnaire, the PSAC, which has 4 subscales to measure changes in appearance, consciousness, satisfaction with appearance, and satisfaction with symptoms, as well as some questions about specific symptoms. And we use the Measure Yourself Medical Outcome Profile, or MIMOP, which is a patient-centered individualized questionnaire that measures the outcomes the patient themselves considers important. We also took photographs to keep a visual record. So our results, we collected baseline data for 19 patients reporting 25 scars. 13 of those patients reported 1 scar, but 6 reported 2 or more scars. And we had complete end of treatment data for 15 patients reporting 19 scars. So our patients, 2/3 were female, 1/3 were male. The tumor types, just about half were head and neck cancer, just over 1/3 were breast cancer. We had 10% colorectal and 1 melanoma patient. We gave a total of 115 scar work treatments, and no serious adverse events were reported. And in this group, the average age was about 64 years old, but that ranged from 39 to 82 years. The scar age in years since surgery was an average of 4 years, but that ranged from 6 months to 17 years. And the number of scar work treatments were an average of 6 per patient, but that ranged from 0 to 12 per patient. So looking at our outcomes, here we have a spider plot, and you can see that we have some improvement. The baseline red line on the outside and the end of treatment line, a green in the center, shows an improvement. There is improvement there. And we had significant improvement, that is p is equal to or less than 0.02 on all of the 4 main PSAC subscales. So in appearance, scar consciousness, satisfaction with appearance, and satisfaction with symptoms. PSAC symptoms are reported separately because not all patients will experience all of the symptoms, and the numbers can be quite small. So you can see we have a more variable result here, but we had improvements in all symptoms apart from pain frequency, pain intensity, and uncomfortable intensity. MyMop outcomes again show improvement, and you can see this in the differential between the red bars at baseline and the green bars at end of treatment. T-tests showed significance. P is equal to or less than 0.02 on all domains. The mean MyMop profile score showed a 1.8 points improvement, and on MyMop, a change of half a point or more is clinically significant. So we compared the MyMop symptoms that the patient specified to PSAC, and PSAC was well matched. They were well matched. PSAC was just lacking restricted movement or function, hardness, and negative emotional states. So patient feedback. These patients were very positive about their experience, and they reported benefits in functions, such as this man who had less constriction in his throat from head and neck cancer treatment, and he could test new foods in his diet. A breast cancer patient was experiencing less pain, better movement, and she said it made her feel normal. This other male colorectal patient found he could sit down comfortably, and a very anxious melanoma patient said she was less emotionally upset about the scar on her face and more relaxed. And a female colorectal cancer patient said that this treatment should be offered to everyone who has had invasive surgery. It's beneficial beyond body and mind and part of the healing process post-cancer surgery. So, this is the first systematic assessment of scar work to our knowledge, and it is an evaluation of a pragmatic clinic. So we are aware that there are many limitations to what we have presented here today. But doing this exercise, we learned much about scar presentation, how to treat scars, and how to report the measurement of change in scarring. And we're pleased to announce that we believe that we have published the first publication of scar work outcomes, and that became available online in pre-publication form at the end of April. Our next steps are to conduct a research study. We have funding to look at scar work for post-breast surgery pain syndrome in early breast cancer patients, and this is funded by ScarWork UK, who have raised money through crowdfunding, and the East and North Hertfordshire Hospitals charity. And I'd just like to say that funding is very challenging to obtain for these novel interventions, both for the clinical aspects and ancillary aspects of conducting research. And we seem to be caught in a catch-22 situation where we're asking for funding so that we can develop the evidence base, and funders tell us that we don't have enough evidence for them to justify funding us. So, for further information, I invite you to read the paper that will shortly be available in its published version. That gives further details on what I've presented today. And also, my contact address for any further questions is beverly.devalois@nhs.net. I'd like to thank you for your time and attention. Thank you very much.